My name is Luobin Liang. The topic I'm presenting today is the perfusion strategy for thoracoabdominal aortic aneurysm surgery. This is my disclosure. I have nothing to disclose. So first, I give some background information for thoracoabdominal aneurysm. So the incidence is for 100,000 population, there are 6 to 10 cases per year. And without treated, the 5-year survival rate is only 10 to 20%. And if the patient has come with a COPD, the rupture incidence is increased. And based on the diameter of the descending thoracic aneurysm, so the patient has a different, which means if the diameter is bigger, then there's more chance of getting a rupture. So if the diameter is greater than 5 centimeters, and the incidence of rupture doubled every year for like 1 centimeter increase in diameter. So that's a classification. Based on this, the aneurysm involved area. So it's classified 4 types based on Dr. Crumford. And based on that, Dr. Safi have type 5. So which are only, so that's based on different areas, the aneurysm involved. So for the strategy for doing a thoracoabdominal aorta for perfusion strategy, basically is a spinal cord protection. So as we know, the relation of spinal cord injury for aortic cross clamp, the safety time, the spinal cord is more tolerance for ischemia than brain. Say like at 37 degrees, the spinal cord you can be saved for ischemic at 20 minutes. And based on a different temperature, the time goes up. So, but the spinal cord can be injured in thoracoabdominal surgery. 4 to 14% of patients has this spinal cord injury. So because of the malperfusion or hypertension or the vasospasm and or edema or thrombosis. So the strategy for preventing this spinal cord injury is like we can increase the spinal cord blood supply by maintaining a little higher blood pressure, like maintain a mean arterial pressure at 80 to 100 millimeter mercury. And you can also do a reattachment of intercostal artery. So also we can do like a CSF drain to protect the spinal cord. So also we can reduce the spinal cord ischemia by correcting the anemia of the patient situation. Also, we can provide extracorporeal circulation, like doing some kind of cardiopulmonary bypass, or to provide a distal perfusion or left heart bypass. Based on that effective monitoring, and also we can give some mild hypothermia, so they can protect the spinal cord injury. The ischemia tolerance for abdominal vessel is much longer. So the safety ischemic interval for abdominal vessel, it probably is much longer than spinal cord at the same temperature. The significant injury appear to occur at 28 degree at 120 minutes. The lethal injury is likely. So although the kidney is more sensitive, the liver is the next, and the bowel is the least. But the consequence of the difference, the organ has injury happen is not follow this order. So that's based on the patient. Different patients have different kind of situation. So the use of extracorporeal circulation during a thoracoabdominal aortic aneurysm repair. So it's you can decrease the spinal cord injury, and also it can decrease afterload. You can preserve the airway function and decrease aortic insufficiency. For organ protection, you can improve the perfusion and decrease the vessel ischemic. So this paper is by Dr. Safi. He summarized 10 years cases of thoracoabdominal cases. So he can his conclusion is the use of adjunct independently reduced the risk of mortality and mobility. And he also advoked the use of distal perfusion in all type of thoracoabdominal aortic surgery. So by using this adjunction of distal perfusion, you can decrease the spinal cord injury to 2.4%. Also, this paper is by Dr. Coselli. So also see the selective left heart bypass. He used that for about 40% of his cases. He summarized his over 2,000 cases of thoracoabdominal aortic aneurysm cases. So 40% of the cases he used a left heart bypass. So he can reduce the mortality to 5%. Also, he can reduce the spinal cord injury to 5%. Also, another paper is by Dr. Patel from Columbia. He did a meta-analysis. He summarized a lot of patients with thoracoabdominal surgery. He summarized almost 2,000 patients doing a thoracoabdominal aortic surgery without extracorporeal circulation, and also the other 2,400 patients with some kind of bypass, some kind of extracorporeal circulation. So you can see by using extracorporeal circulation, you can significantly reduce the death rates and also any complication, including a pulmonary and kidney injury. So the survival rate is also increased by using extracorporeal circulation. So extracorporeal circulation used during thoracoabdominal aortic surgery repair is associated with a lower 30 days of mortality and lower 30 days respiratory, renal, bleeding complication. Can also decrease the cost. It can improve the long-term survival. So his conclusion is, unless there is a contraindicated for a technical or a clinical reason, extracorporeal circulation should be utilized as an adjunct during a descending thoracic aneurysm or thoracic aortic aneurysm repair. There's another paper is by Dr. Lancaster from Boston. He also summarized patient compare is a patient just using a clamp sole without any distal perfusion, and also patient with some kind of the distal perfusion. So you can also see the survival rate is much increased by using distal perfusion. So the perfusion strategy for thoracoabdominal aortic surgery is based on different type of this thoracoabdominal aneurysm, we have the different type of strategy. So for type 1 or type 4, the involvement, the aneurysm more limited in thoracic or abdominal. So usually we use a normal thermic, just a clamp and a sole, and then we can use also we can use a rapid infusion. For the type 2 or type 3, it's the thoracoabdominal aortic aneurysm involve more broader area, so we can use some either by using a full cardiopulmonary bypass with descending with a deep hypothermia circulatory arrest, or some kind of a partial cardiopulmonary bypass, either using an open system with a femoral vein and femoral artery cardiopulmonary bypass, or a closed system like a MEAC system for femoral vein and femoral artery cannulation as cardiopulmonary bypass. Also, you can use a left heart bypass. Some centers using a left heart bypass as well. So this picture is that's showing that's for the type 1 or type 4. We're just using a clamp and sole. We are not using any bypass. We're just using a clamp sole and rapid infusion. We use a Harlan machine as a rapid infuser. So and using a cardioplegia set to do we can control the temperature, so we can warm up the blood, so we can we're doing a rapid infusion. So that's the usually we use the patient for type 1 or type 4. You don't have to using any bypass. So this type of for the type 2 or for the type 1, for some kind of thoracoabdominal aortic aneurysm, if you are unable to clamp the proximal, like a type 1 or type 2, patient has a post intravascular intervention or has an endo leak at the anastomosis area after a frozen elephant trunk. So those kind of patients, if you can clamp the proximal, so you have to use like a femoral vein and femoral artery cannulation for full cardiopulmonary bypass with deep hypothermia circular arrest. So this one, so that's a picture showing on this slide is showing you can just like a regular, you can use a cannulated femoral vein and femoral artery. Then you use this way, you can cooling the patient down, and then after that you can stop the circulation, and then just open up the proximal of the thoracic aorta. You can doing anastomosis. After that, you can using a set branch of the graft. Then you can put another branch of arterial cannula over there. You can starting warm up the patient. So usually this kind of procedure, you can do less dissection of the around aorta. So there's no need to cross clamp. You can just cooling the patient down, and then when patient reaching the temperature, target temperature, you can just stop circulation. The easy to expose the distal aortic arch. You can also because it's you deep hypothermia circular arrest, you can provide a bloodless field for the surgeon, and also for the surgical bleeding. So bleeding in the surgical field, you can also collect in the reservoir, and then using a Harlan machine, the pump sucker of the Harlan machine collected to the reservoir, it can transfusion back to the patient. By using a hypothermia, so you can protect the central nervous system, also heart and organs for protection. You don't have to like doing a kidney or abdominal vascular perfusion. So this type of surgery we use it because of a full bypass. We use a full hypernization. You're using a peripheral cannulation. Usually we use a VAVD for that kind of procedure, and then we're cooling the patient down to 18 to 20 degrees. And then we'll try to limit it, the upper body circular rest time is limited less than 30 minutes. So another type of, if the patient, the proximal thoracic aorta, you can clamp that, then we can use a femoral vein and femoral artery partial cardiopulmonary bypass. This is not like a life heart bypass. You don't have to cannulate left atrium. So it's easy to exposure and operate. And also, after you clamp the proximal descending aorta, so actually the heart is perfused the upper body, and then your cardiopulmonary bypass, your Harlan machine is perfused the lower body, and this is a partial cardiopulmonary bypass. Usually you use a flow like a 1.5 liters to a 3 liter flow. And this procedure you can do an open system. You can also do a closed system like a MIAC, like what I would talk detail in later on. So this gave a better, because there's an oxygenator involved, so get a better oxygenation, especially for patient with a lung injury. So we can use a regular pump circuit. You can use like a roller pump or centrifugal pump. You can still use a hard shell reservoir. There's an oxygenator. You can use a pump sucker. So this is like using a regular pump circuit. And for the blood in the field, you can collect into the extracorporeal circulation, and then you can transfuse back to the patient. That way you can preserve the clotting factor and the platelet. Usually we're doing this way is a normal thermic because you don't want cooling the patient down. You don't want the heart to get fibrillating. So the heart still perfuse the upper body. So you can do either a normal thermic or mild hypothermic. It's usually like 35 degrees. If you use a lot of irrigation, you can still using a hemoconcentrator because that's a regular pump circuit. So you can so this type of circuit you can very easily convert to a full bypass with a deep hypothermia circulation. If based on the situation change, if the patient you can have able to clamp the proximal, or you have to do some kind of work on the arch repair. So for this type of procedure, we use a full hypernization, so like easy to anticoagulation management. So this by this way you can provide myocardial protection, also control the preload and the venous return. By control the proximal blood pressure and the ventricular tension. So that way it can The only bad way is because there's a femoral cannulation, arterial cannulation, there's a retrograde perfusion. So a patient has a bad aorta, has a atherosclerosis patient. So you have to be very careful. They can cause like the plaque, you know, the retrograde, the flow, they can dislodge the plaque and cause you know, emboli. So this picture showing that's the partial bypass, or called a femoral vein cardiopulmonary bypass. It's an open system, so it's still using hard shell reservoir. So the hard part for this, you have to control partial clamp the venous return, venous line. So you have to control the venous return. So by maintaining a certain volume to maintain the upper body pressure. So that's a hard part. Then you have to like at the same time you have to using adjust your pump flow to provide enough blood perfusion and blood pressure for the lower body. So this is like you always have to like constant adjust the drainage and your pump flow. So then you can using by improving that, you can use a minimal invasive extracorporeal circulation like a MEAC system. So you know that way. So I just gave a bit background information about this MEAC system. MEAC system is usually take out the venous reservoir. They use a patient body as a reservoir to control the volume. So the circuit is easy. You can drain the patient, you know, to a centrifugal pump and the pump to an oxygenator and then back to the patient. So based on a different arrangement or setting up, either involve the reservoir or not, they can have a different type, have the type 1 or 1 to 4 different type of MEAC system. So the advantage of a MEAC system is that there's no venous reservoir. There's a closed system. So using a centrifugal pump, so you can reduce the blood cell damage and hemolysis. So you can still using a LV vent or pump sucker or a root vent, just like a regular, we're pumping a regular or the other open heart cases. If you know, if you combine using a blood microplage, you know, for MEAC, you can even further to reduce hemodilution. So that's the advantage of MEAC system. So the MEAC system can reduce blood foreign surface contact, reduce the inflammatory response. It's easy to assemble and take down, has a more flexibility. So you can also use, they can use many different kinds of cardiac surgical procedure. So the MEAC system was incorporated 2019 European guideline. Also it's US and European guideline for patient blood management. So this is a closed system we use for the thoracoabdominal or aortic aneurysm. So basically, this is you know, you can follow my cursor. So this part is a regular pump system, just like we're doing a regular heart lung bypass, and we're just using this centrifugal pump. So usually, what we do is, you know, here is the venous cannulation. You know, the venous blood coming back to the venous the heart cell reservoir. Usually, when we're starting the bypass, so we drain open the blood is coming back to the venous reservoir. So that time we can taking off some patient's volume. So because there's a lot of bleeding involved and a lot of blood transfusion for thoracoabdominal aortic patients. So usually I try to do a blood management. I try to save a patient's blood. So if the patient's hematocrit is good, so we can just taking off patient's blood, doing a intraoperative auto blood donation. So we can like take off some patient's volume. And patients usually if the patient's hematocrit is low, a patient anemic, what we do is we're still taking patient's volume, but we put a packed cell, the red blood cell to the reservoir. At the same time, we can transfusing back to the patient at the time when we're taking patient's blood out. So what we do is when we're starting the bypass, we drain the patients, we're taking the volumes off. At the same time, we transfusion back to the patient, maintain the blood pressure. Once the volume is taken, so we clamp this venous line to the reservoir. We open this line to the centrifugal pump. So right now, the patient's venous blood coming back to the centrifugal pump and go to the oxygenator, back to the patients to arterial cannula. So this is like a MEC system. Actually, it's like a VA ECMO. So it's a closed system. At the same time, any blood field in the surgical field, you can still use a pump sucker collected in the reservoir, and you can still using this a transfusion pump, transfusion back to the patient. You know, for that thoracoabdominal aortic aneurysm, usually at the end of when they're doing the last part of when they're doing anastomosis at iliac artery, so they clamp the iliac artery or open that. So that way, so usually then you can transfuse back to the femoral artery. That way we can open this bridge. We have a bridge between the arterial and venous line. We can open this bridge, so we can transfusing back through the venous cannula. So that way we can still transfusing back to a patient, maintain the patient blood pressure. So that's the MEC system, the closest system we're using for thoracoabdominal aortic aneurysm. That's some kind of the picture. That's the system we're using. There's a centrifugal pump. So like a patient blood coming from the patient, we drain some blood here. So we can saving the patient's blood, saving all this clotting factor and the platelet. So after taking the blood off, we open this, the blood coming this way, so to the centrifugal pump, back to the oxygenator, and coming back to the patient. That way, what do we do? So that there's a procedure by the surgeon to doing all this abdominal arteries anastomosis. This is the left heart bypass. Some center using left heart bypass. So this the left heart bypass is also use a centrifugal pump. There's no reservoir. It's a closed system as well. Usually, what the cannula is to LA to left atrium to a femoral artery or to aorta to femoral artery. So because it's a closed system, they have no way. Usually, they have no way to transfusion back to the field blood. They have to using a rapid infuser. What they usually use as a Belmont rapid infuser to transfusing any blood that collected from the field. They sometimes they're using 1/3 of heparin for patient coagulation. They maintain a ACT around 200 to 250. Also, they can using some kind of doing some kind of perfusion, perfuse the abdominal artery, the branch artery. They can also to do a kidney perfusion to preserve the kidney. So that's what they do. Because the system, they have no oxygen involved, they have no heat exchanger. They have to use an actual heat exchanger to in the circuit. This is a rapid infuser they use. This begin the procedure. Just begin the thoracoabdominal procedure part. So if a patient just starting, they're using a regular like a cell saver system, and after starting the left heart parts, so they will convert to a rapid infuser. So this rapid infuser, they can quickly warm up the blood and transfusion back to the patient. So that's what they use the Belmont system. So for thoracic abdominal aortic surgery, we're using usually we use some kind of neurological monitoring to guiding our surgery or perfusion strategy. We're using oxygen, the cerebral oxygen oximetry, or any the potential monitoring to monitor guiding the surgery and the perfusion procedure. We're also using a CSF drain to protect the spinal cord. We usually drain the CSF drain during the aortic clamp. We usually try to maintain this lower than 15 millimeter mercury, and then the early post-op we maintain 15 to 20 millimeter mercury, and then based on the post-op how the patient doing. So we usually DC this CSF drain at 24 to 48 hours. But you don't want to drain too much. You don't want to keep the CSF pressure too low. That's also can cause a complication because such as intracranial hematoma or intramedulla hematoma. This is a summary of our 7 years, almost 6 years in our hospital for all the thoracoabdominal aortic surgery procedure. I calculate to the end of last month, we totally doing 400 cases. So that is our case distribution each year. So right now we're doing like 70 to 80 cases a year, this kind of procedure a year. So for 2021 or 2022, because of the COVID, so the case was a little down. So that's this picture is showing the distribution, the method we're using. So right now we're mainly use femoral vein and femoral cannulation for cardiopulmonary bypass, either open system or closed system. We're using an open system before, but since like I think 2020, so we convert to a closed system of femoral vein, femoral artery, cardiopulmonary bypass. Some kind of a procedure for limited type of thoracoabdominal aneurysm. We're still using we're not using any bypass. We're using a clamp and sew technique. We seldom using a light part bypass. We tried a couple of cases. So the result is not that great. So we just right now we're still using by a femoral vein, femoral artery, partial cardiopulmonary bypass is a main procedure for type 1, type 2, and type 3 procedure. So we summarize this from 2016 to 2021. We're doing like that's all the cases we've done. We compare to them the patient with different comorbidity with hypertension, diabetic, and coronary artery disease and stroke or smoke. A patient has a Marfan syndrome. That's patient distribution, and then the previous surgery the patient has. Most of patient has a previous aortic surgery, like 70% of patient has previous aortic surgery, and then that's the type the procedure we done, different type of thoracoabdominal aortic aneurysm we done. So you see, type 2 or type 3 is still the major part of or a procedure is usually like a type 2 like almost 40%, and then type 3 is 30%. We also have we did like 20 cases emergency thoracoabdominal aortic aneurysm. So there's like 8.4% is an emergency procedure. That over time is almost 400 minutes, and then the intubation time is 38 minus plus 115 hours. We ICU stay, that's the ICU stay, and also they compare that's the information about all the PEC cell and the blood component we're giving to the patient. We use a deep hypothermia circular arrest on 49 cases. It's 20% of cases we're using the deep hypothermia circular arrest. And also have 3 patients we end up on ECMO. We have 15 patients, so post-op have using a CRRT for kidney problem. So for this group of patients, 2016 to 2021, there's almost like 200 something patients. The paraplegia risk is happened 8%, and then the serious complication is 5%, and the renal failure is almost 6%, and 8% for deaths. So to summarize, the thoracoabdominal aortic perfusion strategy, what we do is based on patient's condition and the pre-op, the radiology result, and also patient had the previous the reoperation, previous surgery or reoperation situation. We individualize the perfusion strategy. For type 1 or type 4, so for that involve more limited to the thoracic and abdominal. We're not using any extracorporeal circulation. We just use clamp and sew with a rapid infusion. For type 2 and type 3, which involve a more broader area, so we use the distal aortic perfusion by using if the patient can the proximal thoracic aortic can clamp, then we use a MEAC system like a femoral vein and femoral artery cardiopulmonary bypass. But the patient cannot clamp the proximal thoracic aorta. So usually we're using a femoral vein and femoral artery with a full bypass with a deep hypothermia circular arrest. Then we'll try to limit it the upper body arrest time is less than 30 minutes. And for anticoagulation management, we're all using full hypernization. This avoid any coagulopathy. So it's easy to management, just like doing open heart cases, regular open heart cases. For neural protection, we use a NEAR system. NEAR is for the neural monitoring in deep hypothermia circular arrest. And also we're using, for the surgeon to reattach the intercostal artery to prevent spinal cord injury. And also a post-op, and then during the procedure on the post-op, we also use a CSF drain. For the perioperative blood management, like I said before, we use all 3A circuit to try to minimize the prime, minimize the hemodilution, and also we integrate the integrated oxygenator, so we don't have to use a separate arterial filter. So we try to, every patient will try to take blood off, doing an intraoperative autologous blood donation. For every patient, every cases, we're using an auto transfusion. And we're also using, for kidney protection, we use a cold kidney perfusion, and also for abdominal vessel organ protection, we use we perfuse the abdominal vessel artery branch as well. And also, for this kind of procedure, it's a team work, so you have to be has a good communication and teamwork. Thank you very much. That's my presentation. Thank you. Like any questions? We're using a MEAC. When using the MEAC method instead of femoral CPB, do you find you run into a volume issue at our center? We find we need to use a lot of volume on femoral. Oh, this for this question is if you use a MEAC system for the volume, you can add volume. You can add blood or add based on the patient's hematocrit. You can use either a Hexel. You can add a crystalloid. Adding to the reservoir. You can transfuse it back to the patient. That's how we manage the volume issue. So because the upper body blood pressure is totally based on the patient's blood volume, so you have to maintain a certain good volume to maintain upper body blood pressure. Okay, thank you.